the prototype approach in dentistry, why it works, and how to implement it. We want to start by thanking our sponsors, Colteen, Oral Arts Dental Laboratories, and Romero Dental Seminars for making this webinar series possible. We also want to direct all our followers to our YouTube channel, Romero Dental Seminars, where you will find more than 100 educational videos related to dentistry, basically to restorative dentistry. And all these videos are free for you to watch. So please don't forget to subscribe to our channel and to share with other colleagues. Our objectives for today are going to be understand when a prototype is needed, learn the preclinical steps for a prototype, and highlight the step-by-step protocol. So let's get started. When is a bonded prototype needed? Well, I want to start by sharing with you this scan of the case that I'm going to share with you today. As you can see, the patient presented to the practice with excessive attrition and erosion at this point on all mandibular incisors and attrition on the cusp tips of the mandibular canines. Now, I also want you to see, and I'm pointing here with my cursor, that the pulp chamber at this point, is very close to being exposed. All these teeth are vital. And this is crucial because this is what we have to understand. What are really the clinical options for these patients? And when would a bonded prototype be needed? And this, for me, is a classical case where you have excessive attrition and at this point combined with erosion that definitely would require a prototype if you want to have a very conservative approach. Now again, I'm showing you now the full scans, full upper scan and lower scan, and I want you to see that not only that the patient has had a slow but progressive attrition and erosion of the mandibular incisors and the canines, but also he has had over eruption of maxillary incisors going from 7 all the way to 10. If you look at the incisal edge position of 7 through 10 and compare it to the incisal or cusp position of 6 and 11, you can see how much these teeth have also over erupted. Why? So that they can compensate for the interocclusal contact that needs to be established. So when we think about this and when we're reviewing a case like this, we understand at this moment that the envelope of function, that relationship between the incisal edges of mandibular incisors and the lingual contours of maxillary incisors has been compromised. And this is what really needs to be restored in this stomatognathic system. Again, I'm showing you the full arch maxillary occlusal view, maxillary scan of and the full arch mandibular scan from an occlusal standpoint. Now, I want you to focus for now only on the anterior guidance. So let's look at the lingual surfaces from canine to canine. And again, I want you to visualize, you can see how much attrition and combined at this moment, as I said before, with erosion noted on the lingual contours of 7, 8, and 9. And you can also see how these mandibular incisors have now eroded away and created a step on the lingual surfaces of these teeth. Now, these teeth have over erupted, these teeth have excessive wear, but this is now the envelope of function that this patient presents. The only teeth that has less of an alteration is tooth number 10. But you can see how aggressive this ceramic restoration that has lingual coverage compared to the veneers that the patient has on 7 through 9, but this ceramic restoration has created this excessive attrition and erosion on the incisal facial aspect of this tooth number 26. So when you have ceramic and when there is an improper envelope of function restored on a patient, you are going to see this type of wear. And at this moment, you have to ask yourself, what are my clinical options? What can I do in order for me to restore this stomatognathic system back to function? So from a clinical standpoint, you really only have, in my mind, at least three options. Again, if we were to discuss this case, with other colleagues and maybe sit down and discuss it for an hour or two, we may come up with other clinical alternatives. But for now, I want to just share with you a couple that came to mind. And one of these is the one that, this patient came to me with just to request a second opinion after receiving a chewing plan by another provider. But option number one, in my mind, would be root canal treatment on all these mandibular incisors, due again to the closeness of the pulp chamber of these teeth with the oral environment. Very thin remaining dentin thickness on top of that pulp chamber. So root canal treatment and a crown on all and crowns, I'm sorry, on all mandibular incisors and canines. And this would be to reestablish, that envelope of function. But in parentheses, I've written here the continuous, or to continue with the circle of death. If you think about it, if I were to remove the pulps from these teeth, which at this point, they don't need for me to do that. These teeth are vital, responding correctly to cold, no symptoms to percussion, and no symptoms to, no sensitivity or no discomfort with any hot substances. If I were to do root canals on these teeth and prep these teeth and maintain the same vertical dimension, how much tooth structure would I have left in order for me to cover with those crowns? How rigid or how resistant to the occlusal forces would these teeth be? Would there be any risk of these teeth fracturing at the cervical end and then probably requiring extractions and implants? So you got to think about this. When we're doing this, when we're treating cases like this, what you want to try to do is that you want to be as conservative as possible. And there are so many other techniques that we can use that would benefit this patient and that would make it a lot easier for us to restore those mandibular incisors compared to root canals and crowns. Let's look at option number two. And this is actually the option that the patient was presented with prior to coming to my office. And it was extraction of mandibular incisors, 2 implants, and an implant supported fixed dental prosthesis. So they were planning to extract 23, 24, 25, and 26, place implants at the 23 and 26 position, and then a 4-unit implant supported fixed dental prosthesis. Now again, what interocclusal space would you have? Number one, in order for you to restore that envelope of function. Number two, if at this vertical dimension there has been so much destruction of these mandibular incisors, why would placing implants and a fixed dental prosthesis work for this patient? Why would they not be submitted to the exact same forces that have created destruction of the existing mandibular incisors? So we got to think about that, because if you only extract those teeth and place 2 implants, all you're doing is restoring the effect of what we are seeing, but we're not really eliminating the causing factor. We're not really altering at all or figuring out what is the position of the condyles in the glenoid fossa. So from a occlusal standpoint, how much are we really doing for this patient by limiting our work or our restorative treatment to those mandibular incisors? And the final third clinical option is what I call a segmental increase in the vertical dimension of occlusion combined with the doll effect. And this is what I recommend for this case. This is the way that I decided to manage this case. And I obviously explained to the patient what this entitles. And this is what I'm going to also convey to you that are listening to this webinar. So let's go to objective number 2. Learn the preclinical steps for a prototype. So of course, step number 1 for something like this would be for us to have either impressions or a scan like I'm having here of the upper maxillary arch and the mandibular arch. Once we obtain the scans, and this is step number 1, or again just an analog impression, we either pour the cast or we go ahead and move to our second scan, which is going to be a scan of the bite. Now, it is right here at this moment that we have to make a little alteration of a regular interocclusal record or scan. And for this what I'm going to use is I'm going to use a leaf gauge, and I'm going to place this leaf gauge right in between the maxillary incisors 8 and 9 and the mandibular incisors. And when I place my leaf gauge, I'm always going to ask my patient, and I'll start with one or two leaf gauges, and I ask my patient to move their jaw forward all the way up to an edge-to-edge position, and then to go right back into the mandible, trying to make all their posterior teeth come into contact. Now, of course, because they have the leaf gauge in between the maxillary and mandibular incisors, posterior teeth should not and will not contact. But what I do then is I wait a minute or two, a minute or a minute and a half. And during that time, what I'm allowing is the elevator muscles to relax and the inferior lateral pterygoid muscle to release its contraction. And by doing so, what I should expect is that maybe a minute or a minute and a half later, the patient may feel some posterior teeth contacting. And if that's the case, then I would add one or two leaf gauges until the patient, again, does not feel any posterior teeth in contact. Again, I will have the patient move their jaw forward all the way up to edge, and then come right back to try to accomplish maximum intercruspation. Again, because the leaf gauge is in front of the maxillary incisors, there will be no posterior teeth in contact, and then I will wait a minute or a minute and a half again. When do I stop adding these leaf gauges? I stop adding the leaf gauges once a minute or a minute and a half go by and the patient doesn't feel any posterior tooth in contact. What is that telling me? It's telling me that the inferior lateral pterygoid muscle, from a physiological standpoint, has released its contraction, and the condyles, the medial pole of the condyles, are up against the vertex of the glenoid fossa in centric relation. So that is how I establish centric relation at the increased vertical dimension for this patient or for any other patient that I'm going to be doing exactly the same procedure. And what you are seeing in this scan right now is actually that relationship that I was able to record with my scan, obtaining a left and a right occlusal scan with the leaf gauge interposed in between the central maxillary central incisors and the mandibular central incisors. So now you can see that I've created enough space for me to restore without cutting or removing any tooth structure all the way from canine to canine on that mandibular arch. And I also am going to have to, of course, add some composite, most likely to the maxillary lingual surfaces from canine to canine. And I'll show you what that looked like, what it looked like after I was done with my wax up. But for now, I want you just to visualize this is the new vertical dimension. This is the increased vertical dimension that I am going to where I'm going to restore this patient temporarily with my prototypes, and I'm only going to focus on that anterior guidance. So by doing this, once I have this done, once I have this scan, what I do is I went and I go ahead and I submit it to my dental laboratory. So I submit this to the lab, and what they're going to do for me, what I'm going to ask for them to do is I'm going to ask them to wax up digitally a new curve of occlusion going from canine to canine on the mandibular arch. And once those mandibular teeth are waxed up digitally, then to add any wax needed on the on the lingual surfaces of the maxillary incisors and canines to recreate a new envelope of function with these mandibular incisors completely restored. And that's what you're seeing here. What you're seeing here is a 3D printed model. You can see the excessive wear on the left hand, on the photo on the left hand. You can see the excessive wear on the scan and on the 3D printed model on all the mandibular incisors and canines. And what you're seeing on the photo on the right is now a beautiful wax up that also recreated a new canine cusp that would allow this patient to have canine guidance. But of course, because we're only adding wax to the anterior guidance and none on the posterior teeth, this is going to increase. That's what we call a segmental increase of the vertical dimension. We're going to increase the vertical dimension segmentally, only adding to the envelope of function. Once we have these casts, what we're going to do is that we're going to create we're going to take an impression using a clear PVS of this wax up, mainly for the mandibular incisors, so I can use that clear PVS to take this wax up into the patient's mouth and restore those teeth exactly at the same incisal height and exactly reproducing that new envelope of function once I do the same on the mandibular, on the lingual surfaces of the maxillary incisors. So this takes us now to our objective number 3, which is to highlight the step-by-step protocol. What does this look like from a clinical standpoint now directly into our patient's mouth? And you can see now, I have now using that clear PVS, I have literally taken this wax up and using a highly filled flowable composite. For this case, I use Brilliant Everglow Flow. I injected that Brilliant Everglow Flow to the clear PVS after acid etching and adhesive application on all those mandibular incisors and canines, and then seeded that clear PVS, and this is what I got. Again, I'm just doing this. I'm going to connect all these teeth together. And I do this because it makes it very quick, very easy, and very predictable. You can see that the wax up, because of that clear PVS, is so runny, it literally adapts beautifully well to this wax up. And because I only asked the lab to literally add the wax from the fracture surfaces all the way to the new position of the incisal ledges and canine cusp tips of those mandibular incisors and canines, you can see that there's nothing on the cervical third. So I haven't added in volume to these teeth. All I did was add to the length of the teeth. And this is what makes it so easy, because this clear PVS adapts so well to the underlying tooth structure. So it makes it very easy, very simple, very little flash that is left over after you do this. So this is immediately after I delivered the prototype to the mandibular incisors, and then I did the same thing to the maxillary incisors, and I'm going to show you that. Of course, if I have now my patient bite down in these prototypes, you will see that all the posterior teeth are going to be separated, and this is what the doll effect looks like. So the doll effect, as we all know, what is telling us that if you segmentally increase the vertical dimension, in approximately 8 to 10 weeks, you're going to get full occlusion. You're going to get intrusion of those mandibular incisors, intrusion of the maxillary incisors, at the same time that you get some extrusion of the posterior teeth. So the ultimate goal is to accomplish, for this particular patient, full occlusion on those posterior teeth. Now, for this particular case, I am going to redo all the ceramics. And this patient, we had to extract 2 teeth, and these premolars were extracted, and some implants were placed there. So we're going to do a full mouth rehabilitation. So I'm going to wait 8 to 10 weeks, and regardless if I obtain or not a full contact between these teeth, I'm going to start removing those crowns, and I'm going to start, putting my temporaries on. But that is not what I want to try to convey with you today. My goal to convey with you today is how to use these prototypes in order for you to increase segmentally the vertical dimension and allow these teeth to intrude and extrude until you get to full occlusion. And of course, in order for me to control how fast or how much these teeth are intruding or extruding, what I do the same day that I fabricate these mandibular prototypes is I obtain with Regisil a bite registration of the left and the right side. So I only put Regisil on the occlusal of the premolars and molars on each of these sides, and I have the patient bite down until my prototypes come into contact. Once I establish that new vertical dimension, I'm going to use that bite registration in order for me to, 15 days later, 8 weeks later, a month or 2 months later, whatever time it takes, I'm going to use that bite registration in order for me to determine how much have we been able to intrude and extrude these teeth, and how much changes are we obtaining in this new occlusion. But what I wanted you to see is I wanted also to share with you what the maxillary arch looks like. You can see that I've added composite to the lingual of the canines. I added composite to the lingual of this lateral incisor, and I had to add some composite to the lingual on the ceramic. I bonded directly to the ceramic on the lingual of this other lateral incisors. I did not have to add to the lingual surfaces of 8 and 9. So this is how I was able to recreate a new envelope and function after I restored these mandibular incisors. And here is the pre-op scan. You can see how those canines were literally, 2 to 3 millimeters shorter than the laterals and centrals. But after my prototypes, you can see how I was able to now reestablish a new canine guidance using my composite resin to reestablish it. So this is how this prototype worked on the lower and the upper teeth, and you can see now my full prototypes on the maxillary incisors, lingual surfaces, and the canines, and the same on the mandibular incisors and canines. And you can also see how I was able to establish centric stops and canine guidance because I don't have any tooth on the back interfering with this new segmented increase in the vertical dimension. Now, the other thing that I want to tell you is that we know that 80% of the elevator muscles will be shut down while posterior teeth are not in contact. So I'm also using that physiological response of the body in order to benefit me and not overload this anterior guidance. Now, of course, you don't want to do this on a patient that has any periodontal compromise of any of the maxillary teeth. These teeth are very nice and stable. Were nice and stable at the beginning of treatment. They're still nice and stable now. We did have some periodontal issues and bone loss and hypermobility on these premolars, and that's the reason why those were extracted, and implants are going to replace those once we are finished with this case, which we are not. But I want you to know that that's something that you need to keep in mind. Now, because these teeth are healthy and you have reduced 80% of the contraction, the force of contraction of the elevator muscles because your posterior teeth are not in contact, that is how we allow this dull effect to work without creating any damage to these anterior teeth. So this is what you're seeing. Step number 4, we're done with our prototypes on the mandibular arch and the maxillary teeth, and we're also done. We've created a new anterior guidance. Now all we have to do is just kind of wait, follow up on the cases, and that's what we're doing here. I want you to watch this video. I'm putting an articulating paper that has 12 microns, and you can see that I'm not able to pull it out. Patient has full contacts on all mandibular and maxillary incisors. But 15 days later, I was able to now you can see that I have the bite registrations on the posterior teeth, and now I'm able to pull this paper out. There's a very little drag. You can see how I'm able to pull it out. There's just a little bit of tug, and this means now that my anterior teeth have intruded while the posterior teeth have extruded. This is the reason why I take that bite registration immediately after I segmentally increase the vertical dimension. And I'm going to use the bite registration with the Regisil on posterior teeth only. I'm going to use it every 2 to 3 weeks to make sure to show the patient and to show myself how much intrusion and extrusion of the teeth we have accomplished following every 2 to 4 weeks. It normally takes 8 to 10 weeks, and it can also take sometimes a little bit less or a little bit more. But it helps us kind of calibrate where we're at and when we would be ready for the next step in this patient's journey to full mouth rehabilitation. So I hope again that this clinical information is useful for your everyday dentistry. I want to thank everyone that follows our channel and everyone that watches our videos and shares our videos with other colleagues, because if it wasn't for you, our channel will not be what it is today. So thank you very much for watching, and see you on our next webinar.